morning, evening, or afternoon. We have exciting presentations and discussions on a very timely topic. And I want to welcome everyone, and I would like to also urge you to ask questions or discuss the issues. Let me begin with a quick background. In 2009, China implemented a major system reform to achieve universal health coverage. What makes China somewhat special is China adopted the best practice around the world after deliberated for close to 5 years to decide on the set of reform measures. That to take a system approach, China adopted a strategy to do a systemic reform, which means changing the financing of healthcare, change the delivery of healthcare, and that's done through the payment changes as well as the regulations. But China went beyond that. China wants to shift its resources on healthcare to primary care and secondary facilities rather than being a hospital-centric system. And moreover, as a middle-income country at that time in 2009, China did not have the resources, financial resources, to finance all healthcare services. China had to leave a portion to the marketplace. So the universal health insurance covered the basics, and the left other portion to the private market, which creates a competition then between the public funded services, which mostly funded the public facilities, but meanwhile left the private to the private insurance as well as patients' own pay. So with that background, we're fortunate to have 4 bright, young, promising health economists from China who have taken a portion of the data to analyze a part of the performance of this reform. I will introduce them each one, as well as at the end, I will introduce the discussants. So without further ado, I would like to ask Xue to begin your talk. And I'd like to remind you, you only have 8 minutes, and I'm going to remind you by the end of 7 minutes. Please take it away.
Okay, thank you for Professor Shaw's introduction.
Then let me introduce you first.
Oh,
Sorry.
okay.
Xue Qingping is from Western China University, and she is in the last part of her PhD program, and I believe this paper is really part of her thesis research. She wrestles with a very interesting question. When China left a portion to the private market, how does the private for-profit hospitals compete with the public hospitals on quality of care? And then please enlighten about your study and findings.
Okay, thank you for Professor Shaw's introduction. It's my great honor to deliver a presentation on the relationship between hospital ownership and in-hospital mortality and medical expenses in China. I will give a brief background of the development of private hospital in China. The private hospital joined the healthcare system since 1980, but they developed slowly until 2009, when the Chinese government launched a new healthcare reform. One of the key policies put forward was to relax the restrictions on private investment in healthcare sector. The policy was primarily aimed at increasing the total capacity and competition within healthcare market. In this setting, the private hospital, no matter the not-for-profit and for-profit, developed rapidly, and the number exceeded the public ones since 2015. But there are long-standing debates on the performance among the three types of hospitals, theoretically and empirically. Some believe that private for-profit hospitals are more cost-effective. Others believe that private not-for-profit hospitals are more efficient. And others believe that public hospitals could afford a more equitable healthcare system. Confronting with these theoretical contradictions, a number of studies explored the performance, in particular the quality of care and medical expenses among these three types of hospitals globally. But the results were mixed and highly dependent on the regions and the market structure. In China, limited studies explored the disparity in quality of care and medical expenses among these three types of hospitals in patient level, which could better control the patient case mix. And so in the midst of the healthcare reform and the rapid development of private hospitals, it's important to assess the disparities in quality of care and medical expenses among the three types of hospitals in China for further reform. So we chose Sichuan province as our study area and collect data from the discharge data, which covered each inpatient in Sichuan province during the fourth quarters of 2016 to 2018. And in order to better control the heterogeneities of diseases and the patients, we chose three representative diseases, including acute myocardial infarction and heart failure and pneumonia for our study, because these three diseases were frequently used in the previous studies to compare these three types of hospitals. And in China, the hospital has three levels, with high level being indicating higher quality of care. In our study, in order to increase the comparability among these three types of hospitals, so we just chose a secondary hospital as our target hospital. As for the outcome variables included the death or not and total medical expenses, and the independent variable included the hospital ownership. As for the statistical method, because the patient nested in the hospital, so we chose the multi-level logistic regression and the multi-level log linear regression to assess the association between hospital ownership and in-hospital mortality and medical expenses, respectively. And we also did some subgroup and sensitive analysis. Let's move to the results, and we can see more than 500 hospitals were included in our research, and the public hospital had on average, had a higher number of bed, medical equipment, and nurse and the doctor than the private hospitals. As for the patient characteristics, we can see there are some differences among the three types of hospitals. For example, the insurance type, the proportion of urban employee basic medical insurance was higher in the private not-for-profit hospitals than public and private for-profit hospitals, same as the Charson score. This table shows the accrued in-hospital mortality and medical expenses for 3 diseases across these 3 types of hospitals. And as we can see that public hospital had lower in-hospital mortality and medical expenses than other 2 types of hospitals. This is the main result from the multi-level logistic regression, and we could find that for pneumonia, private not-for-profit and private for-profit hospital had a higher risk of death than the public hospitals, and no difference found for the heart failure and the AMI. Further, we used the likelihood ratio test to compare the in-hospital mortality for 2 subtypes of private hospitals, and found no difference. No difference were found between the private not-for-profit and private for-profit hospital in terms of in-hospital mortality for these 3 diseases. And this is result for medical expenses. We could find for pneumonia and heart failure that private not-for-profit and private for-profit hospital had higher medical expenses than public one. And also there was no difference between the private not-for-profit and private for-profit hospitals in terms of medical expenses for 3 diseases. This is the result for the subgroup analysis. We found no essential heterogeneities among these subgroups stratified by the age, gender, and insurance type, no matter in hospital mortality or medical expenses. So our results suggested that the private not-for-profit and private for-profit hospitals showed a higher medical expenses for 2 out of 3 diseases compared with the public hospitals. But the private not-for-profit and for-profit hospital delivered equal, even worse, quality of care measured by the in-hospital mortality compared with public hospital. And there is no difference between the private not-for-profit and the for-profit hospitals, both in hospital mortality and medical expenses for all 3 diseases. According to our results, we suggested to build up a public reporting system, which could partially reduce the information asymmetry for patients in terms to promote the hospitals, especially for the private hospitals, to improve their quality of care and reduce their medical expenses. And also, we found no difference was found between the private not-for-profit and for-profit hospitals, both in hospital mortality and medical expenses for 3
1 minute.
Which might be against the primary reasons to building up 2 subtypes of private hospitals, because the 2 private hospitals have different operational goals. So we think we suggest to enhance the governance capabilities, especially for the large for-profit hospital in the near future. Thank you.
Thank you very much for keeping the time, also dealing with a very interesting comparative analysis on the performance of for-profit and non-profit hospitals. Then let me move to the next presenter, who is Deng Qiwei from Xi'an Jiaoda University. And she's going to be presenting how that when there's public for-profit and non-profit and for-profit hospitals, usually hospitals compete by actually introduce the latest equipment and drugs to compete with each other, because the new technology enhance the reputation of the hospitals. And then that drives the healthcare costs to a higher level. She's going to give us the evidence from that, the introduction of the new expensive equipment when there's a for-profit and non-profit hospitals. Take it away.
Okay,
Wei.
thank you for William Xiao, thank you for having me here. I'm delighted to share my work on this organized session about China's healthcare system. I'm on behalf of this work, and the title is Will the Increase of Medical Expenditure Affect Medical Expenses? Evidence from the Perspective of Physician-Induced Demand. During the last 8 minutes, I shall present my work in 4 parts: introduction, methods, results, discussion, and conclusions. The first part is introduction. As we all know about, the United States is a country with the highest medical expenditure in the world. The proportion of all total healthcare expenditure in the United States was higher than that of other OECD countries. The data is shown in the table on the left. Moreover, the cost and expense of medical service have been continually rapidly increasing. The figure is shown on the right. The cost of medical equipment increases year by year. Many studies reveal that one of the reasons for increasing U.S. healthcare spending is the use of new technologies and medical equipment. And also, China has had the social problem of inaccessible and quite expensive medical care. Although many policies have been put forward by the state and local governments, and the total number and cost of medical equipment have been continually increasing rapidly. According to the report from the National Health Commission of the People's Republic of China, the average outpatient and inpatient revenue of each public hospital increased deeply these years. At the same time, the total number of medical equipment deployed in health institutions also increasing obviously. We collected data from medical institutions at all levels in Shanxi province. Shanxi is a landlocked province of the People's Republic of China. The capital of the province is Xi'an. In our research, we mainly focus on the relationship between the number of second-class medical equipment and inpatient, outpatient healthcare expenditure. Large-scale medical equipment configuration management items are divided into 2 categories, first class and second class in China. Second-class medical equipment includes CT, MRI, DSA, SPCT, and LA. Because the first-class medical equipment contains some equipment which is not in the catalog, the main object of this paper is second-class medical equipment, which has been identified. Here is a brief description of second-class medical equipment in the form of a picture. These are common equipment in medical examination areas. And our research question is to figure out whether the deployment of medical equipment is one of reasons for medical expenditure increasing in China. The specific aim are to examine whether an increase in the number of second-class medical equipment would have impact on outpatient and inpatient expense. Furthermore, we want to examine whether an increase in the number of second-class medical equipment would have impact on outpatient and inpatient examination expense. And let's move on methods part. We used balanced panel data of the hospitals to perform a 2-way fixed effect regression to analyze the relationship between the number of second-class medical equipment configuration and the average charge per visit of outpatient and inpatient. Then we employed a difference in difference analysis as our primary statistical methods to assess the relationship between the average charge per visit of outpatient and average charge per visit of inpatient with the second-class medical equipment configuration. And this study used data from health financial annuals in Shanxi province from 2011 to 2017. Finally, we obtained the basic financial data of 199 hospitals. Now I'd like to turn to the results. It's basically displayed in the form of tables. In the study, the dataset includes 199 observations of hospitals and presents accordingly a balanced panel. Descriptive statistics are shown in Table 1. Table 2 and Table 3 provide information about the trend of the expenditure on each patient's visit and the trend of the number of CT machines and MRI machines during 2011 to 2017. And Table 4 is a fixed effect model of average charge per visit of outpatient, average charge per visit of inpatient with a number of second-class medical equipment. There is a significant difference when other variables are controlled for. Then we increase the number of all medical equipment by 1, regardless of the initial configuration shown on Table 5. And Table 6 presents the DID model about the number of second-class medical equipment added by 1, regardless of the initial configuration, with the effect of inpatient, outpatient average charge per visit. As would be expected, DID analysis presents a significant difference on average charge per visit of inpatient with second-class medical equipment added by 1, while other variables are controlled for. It also has an increased trend on expense of outpatient when the second-class medical equipment increases 1 regardless of the initial configuration. And similar results are also found using a more complex model. Table 7 illustrates that the increase in the number of second-class medical equipment increased by 1 with average inpatient examination expense has a statistically significant difference. It indicates that with the increase of the number of second-class medical equipment added by 1 regardless of the initial configuration, the average inpatient examination expense and average outpatient examination expense both have increased in different degrees. And the results lead us to discussion and conclusions. According to our study, the relationship between the inpatient expense, inpatient examination expense, and the number of medical equipment is statistically significant. And the relationship between the outpatient expense, outpatient examination expense, and the number of medical equipment also has a significant trend, but not obvious.
Wait 1 minute.
Okay. The results may have the effect of physician-induced demand, also called supplier-induced demand. In the healthcare system, too much use or treatment does not mean more effective or improving high-quality healthcare. Generally speaking, the average expense should be relatively stable, not due to the increase in the number of equipment or changes in the number of patients. The increase of average charge per visit may be due to the doctor inducing patients to increase the number of examinations so as to meet their own interests. Some studies have also shown that doctors are less likely to induce medical demand if patient's illness is slight or minor, just like outpatient service, because the level of information asymmetry will not be as significant. However, for patients with complex disease as inpatient service.
Sorry, I have to go ahead. Take 15 seconds to finish.
Yeah, just one sentence. The gap is larger, which means the volume of service can be manipulated according to doctor's interest. Thank you. Thanks for William Xiao. Thank you. This is the end of my presentation.
Thank you. That's an interesting analysis. And I'm going to go to the next one, which is Chen Yunwei, who is, again, a young, bright, health economist at UNC Chapel Hill. And she's going to wrestle with this question. China intended to shift the demand and supply to primary care that at the basic level, that is to the towns and the neighborhoods of where people live. And did China succeed doing that? Take the weight, Yunwei.
Thank you, Professor Xiao, for the kind introduction. I'm very happy here today presenting our paper explaining the evolving demand for healthcare in rural China from 2011 to 2018 using a nonlinear decomposition approach. Let me first introduce the motivation of this study. Over the past decade, China has implemented wide-ranging health reforms, and one challenge that these reforms have aimed to address is patients frequently bypass local primary care providers and seek services directly in higher-level hospitals. And this is believed to have contributed to overcrowding in health-tiered hospitals and underutilization of primary care at lower-level facilities. And despite the large scales of health reforms, there has been very few empirical evidence on how rural patient facility choice has been changing and what explains this trend change behind it. So objective of this paper is to examine and explain the changes in bypassing in rural China using longitudinal and nationally representative data from 2011 to 2018. So we first show how the rural patient facility choice has been changing over the past decade, and we then use the fairly nonlinear decomposition to examine how structural changes in demographics, disease burden, infrastructure, and primary care resources have contributed to changes in patient facility choice over time. And what's the value added of this paper? So we all know there has been large scales of health reforms over the past decade, but empirical evidence on these policy impact evaluations has been scarce, possibly due to the complexity of the health reforms and the difficulty in finding a counterfactual when the reforms applies across the entire country. So this study uses a second best approach to answer these questions, like whether policy objectives were achieved, has the bypassing been mitigated, and what are the most important explanations accounting for the trend change, and to what extent the patient facility choice changed because of shifting primary care resources induced by this policy. So we use the data from China Rural Development Survey, which comprises a random sample of 100 villages from 25 rural counties across 5 provinces. And we use the latest 3 waves from 2012, 2016, and 2019. And each wave of this survey comprises 4 components and collected data on villages, village clinics, village doctors, and village household. And we focus on the patient decision to bypass village clinics for the last illness of the previous year and define a dichotomous outcome variables as 1 if the patient used the local village clinics and 0 if they bypass the local village clinics. And in terms of the key determinants, we include both the demand side and supply side determinants and guided by the Anderson Health Behavior Model. And in terms of the estimation strategy, we use a fairly nonlinear decomposition and presents both the aggregate decomposition that estimates the contribution of the entire set of determinants and a detailed decomposition that identifies the individual contribution of each determinant. Let me quickly show you the results from our analysis. As you can see from this figure, the utilization of local village clinics have dropped significantly between 2011 and 2018 from 52.7% to 34%. And this 18.7 percentage point reduction is largely compensated by an increase of using county hospitals. And this signals an increasing burden for county hospitals to provide outpatient services. And at the same time, the share of using township health centers and hospitals outside the county are largely unchanged. And in terms of the trend change in determinants, here I just show a few key findings. So first, there's a significant change in disease composition, with the share of non-communicable diseases have the biggest increase from 15% to 22%. The household wealth increased significantly, and the medical resources, both the number of drugs and the number of village doctors per 1,000 population have dropped significantly. And in terms of our main result from the decomposition analysis, we find the decrease in the probability of using local village clinics is mainly attributable to the compositional changes in determinants, which contributed 57.8% of the total change. And the two largest contributors are the change in disease composition towards non-communicable diseases, which accounts for 33.2% of the total change, and the decreased drug availability that contributed to about 20% of the total change. And to conclude this presentation, we find significant drop in village clinic utilization and county hospital. Okay, thank you, Professor. So county hospitals have absorbed most of the increase in the bypassing activities from rural residents. And our decomposition analysis suggests the structural changes in patient disease patterns shifting towards non-communicable diseases, and the decrease in medical resources at the primary care level are responsible for this substantial drop in primary care utilization. And this finding seemingly contradicts the initial intention of the healthcare reform plan, which has emphasized the development of primary care facilities to manage a growing burden of chronic diseases. So this finding just highlights the infrastructure and workforce at lower level facilities in rural China is still insufficient to meet the patient demand. I still have a slides on limitation, but that's the end of my presentation. Thank you.
Thank you for keeping the time. And that's a very interesting finding about, did China achieve its goal to shift the healthcare to the lower level, the primary care? And I'm going to, we'll come back to it during discussion period, I'm sure. I'm going to move to the last speaker, but not the least. And she's Fan Xiaojing from Xi'an Jiaoda University. She's an assistant professor there. And she's tackling the fundamental question, did China reform improve the equity of healthcare among different populations? Take away, Xiaojiang.
Thank you, Professor Xiao, and hello, everyone. My presentation is about the trends in equity of inpatient health service utilization for the middle-aged and elderly in China. So I will introduce my presentation from the following 4 items. First, the background. So as we all know, equity in health service utilization has always attracted extensive research interest for scholars all over the world. And the rapidly industrialization middle-income country, the widening income-related inequity in access to health services has been a growing concern of the Chinese government. In response, the Chinese government has made substantial efforts since 2003. Yes, this finger shows the policy driving chart showed the health policies that favor people and lower income levels, and these health policies have made significant programs. So the aim of my this study is to assess the trends in equity of receiving inpatient care utilization in China over the period of 2011 and 18, and to provide scientific evidence and recommendations for improving governmental health policies concerning healthcare inequity. Yeah. Middle-aged and elderly population bear a higher burden of chronic disease, depression, disability, and other disease than young people as they grow older. So we assume that their inpatient care is gradually increasing recently. So that's our assume. So the method section. Data in this study were drawn from the 2011, 13, 15, and 18 China Health and Retirement longitudinal studies. This study used a structured questionnaire with a longitudinal large-scale nationally representative sample. Yeah, this is the website of this data. So the main question included information on basic demographics, family, health status, healthcare, and health insurance, and household and individual economy. The baseline data collection was performed in 2011 with an overall response rate of nearly 80. And then 3 follow-up interviews were conducted in 2013, 15, and 18. In this study, in this presentation, this study won nearly 11.912 recontacted respondents were enjoyed. Yeah, this figure shows the flow chart on the sample selection process and each steps. The chart's data employed 4-stage stratified sampling. It was implemented in 2011 to cover nearly 28 provinces in China. The outcome variable, the key variable in our study, was based on respondents' response from the 2011 to 2018 on the following item. So we will ask, have you received inpatient care in the past year? So this variable was a binary variable whereby 0 denoted no and Y denoted yes. Considering the fact that there are huge socioeconomic gaps between rural and urban area in China, so in this study, we analyzed the data separately. So the rural and the urban samples were separately analyzed. Yeah, also in the study, concentration curves, concentration index, and their decomposition were employed to analyze the equity of inpatient health service utilization. And also, logistic regression was employed to analyze the adjusted odds ratio for inpatient health service utilization after controlling for a number of confounding factors and baseline. Now, let me briefly show you my results. So this figure presents the rate of annual inpatient health service utilization from 2011 to 18. The gray one present urban and the orange color present rural. So from this figure, we can see the proportion of urban respondents receiving inpatient health service utilization was higher than that of rural respondents. With regard to urban respondents, 9.98% of respondents received inpatient care in 2011. This value slightly increased to 13.84% in 2013 and to 15.49% in 2015 and more than doubled in 2018. That's nearly 23%. Compared to 2011, the proportion of rural respondents that received inpatient health OS utilization increased to nearly 18%, more than 3 times than the value in 2011. Yeah, table 1 showed the multi-level logistic regression. Yeah, this regression shows that the rate of annual inpatient health OS utilization in 2018 was nearly 3 times higher for rural respondents and 2.5 times higher for urban respondents than those in 2011. Yeah, after adjusted for other confoundings. Oh, sorry. So that's the equity of inpatient health OS utilization. So this figure shows that from 2011 to 2018, concentration curves for both urban and rural respondents lay above the line of equity, indicating that the utilization was more concentrated among the low economic respondents. Yeah, discussion section. This study updates the knowledge on the trends in equity in health OS utilization. And according to the result, we found the utilization of inpatient health OS gradually increased, and economic status, health, lifestyle factors was the main contributors to the prolonged economic inequity. So there are some limitations in our study about the potential unobserved confounding factors.
Sorry,
all the data
your
was
time
collected.
is run out. Can you take 15 seconds, just summarize?
Okay, thank you. Thank you very much. So furthermore, our study needs more analyze covered the inpatient health OS utilization from 2011 to 18 continuously. So that's more research need to covered. That's my presentation. Thank you. Thank you very much.
Thank you, Xiaojia. I know you have done a very comprehensive study and you did not have a chance to present the whole study. But you're wrestling with a very important question is, did the Chinese reform, as big as was, did that actually improve the, reduce the inequity in China? Now, let me turn to the two discussants. We have 4 bright, promising young scholars from China. They're all women, which great gender power, who have done the analysis evaluating the performance of Chinese reform, but the organizer brought in 2 senior scholars to comment on the younger scholars' work. The first one is Karen Crippen, and she was a graduate of Harvard University, earned her PhD, and many universities trying to recruit her, but she decides she's going to be a world traveler. She became a professor at New York University, then to Canada, and now she's associate professor at Hong Kong University. She always has taken a deep interest on China's health systems reform. The second discussant is Terence Chen, who is a senior person, and he has been an associate professor at major Australian universities and very active studying Chinese reform. And Harvard decided to rate him and recruited him to Harvard. Right now, he's a research scientist at Harvard. So please take it away, Karen and Terence. And each one of you have 4 minutes for comments and discussion.
So thank you so much, Bill, for that introduction. And just to comment, if I have any interest whatsoever in the Chinese health reforms, it's because of all the courses I took from you over the years and listened to all your lectures 20 years ago when all this was getting underway. So it's interesting to see this now coming kind of full circle in terms of our ability now to evaluate the impact of some of these reforms. So I only have a few minutes, so I won't take very much time. And I just wanted to comment briefly on the first of the two papers. So I'm going to be commenting on Qingping Shui and Qiwei Deng's papers on basically the two that look at the hospitals. So just context, right? So, both papers have made the case that, the reforms that have been underway in China over the last decade or so have been nothing short of impressive. Essentially the goal is to provide universal health coverage to 1 billion people. The challenges, of course, have also been equally impressive. There have been huge gaps at the beginning in terms of access to primary health care, highly unequal distribution of health resources, in particular between the rural and urban areas, very low qualities of care, especially some delivered in hospitals, and of course, a lack of financial protection in health. And rather than trying to sort of address some of these things, the reforms that have been underway since 2009 and so on have really tried to take on all of these to some extent. And so the reforms include everything from improved purchasing arrangements to the encouragement of the private sector, as well as increased budget allocations to hospitals. Chinese hospitals have always played a very critical role in its health system. They provide the majority of care, they're an important share of total health expenditures, and of course, they've been a subject of much of the reforms that we've seen over the last decade. Historically, service charges, meaning what people pay for actual health services, have actually been quite low. But this has been changing largely in the context of the other changes to the way, for example, they mark up drugs and so on. In the reforms that were underway, we're really trying to rebalance some of these payments that are happening within public hospitals, as well as to increase budget allocations to the facilities. And then also, very importantly, this idea that governments can't do it all, and that therefore there should be an encouragement of the private hospitals alongside some of these public reforms to fill in the gaps. So in terms of the two papers, Terrence and I have split them up. So I'm looking at the two that look mostly at the questions around hospitals. So they fit really well together, in fact. So in hospital-related behaviors and sort of the basic research questions. The two are, do private hospitals provide higher quality of care in the Chinese healthcare context and at lower cost? And did the expansion of investments into new medical technologies lead to increased costs of providing care? And is this a sign of provider-induced demand? Caveats to this is that we really only given the slides, so I'm basing my comments on that as opposed to a deep read of the paper. So the first paper, Shui et al., starts with the observation that one effect of the recent reforms was to greatly increase the number of private hospitals across China, in particular the area in which she was focused. So part of this goal was obviously to increase competition, which could also put pressure on the public facilities to improve quality of care and increase efficiency. And so that really is the research question: does hospital ownership affect quality of care and the cost of care delivered in those services? Roughly, they find that yes, there are some differences with regards to the quality of care between the types of hospitals. However, once they account for a lot of the differences, either between patients, but in particular across the hospitals themselves, they do actually see that a lot of those differences go away, except with some evidence that maybe there are some differences that remain for pneumonia. And however, the costs remain much higher for both private for-profit and private nonprofit hospitals. So there's lots to love about this paper. It's a really interesting paper, great data to look at these things in this context. However, one of the questions I had was, it's dizzying to look at the rate of expansion of private hospitals. In most places in the world, it probably takes 5 to 10 years just to design a hospital, let alone put one in place and have it up and running to a level that maybe we would want to start looking at the quality of care. And so I was quite concerned about the potential confounding effect about the fact that we're potentially looking at quite newer hospitals compared to more established hospitals and how we might account for that. I also wanted to know why only these 3 health services. It seems like a very minor component of what was actually happening in hospitals. And where is this difference between rural areas and urban areas? And that's something that's quite important to think about. The second paper, which is looks at this well-known observation that medical expenses are believed to be on the rise, and they're an important cost driver in many health systems, especially the United States. And so the question is, as China does expand into these new technologies, are we going to see increases in cost of care? What they find is that there are observed increases in both the number of medical equipment in these facilities, as well as the outpatient costs in these facilities. and that the number of equipments was actually associated with higher cost of care in both inpatient and outpatient settings. And this is similar, they did this in both fixed effect models as well as differences in differences models. And the authors actually interpret this as a sign that physician or supplier induced demand might be driving these results. In terms of my sort of comments on this, McGuire's in the, I think it's the Oxford Handbook, describes physician-induced demand as physicians' influence a patient's demand for care against physicians' interpretation of the best interest of the patient. Therefore, I thought, just by the virtue of the fact that people are paying more for these services doesn't necessarily mean that it's actually physician-induced demand. We would also want to look at, for example, health improvements or the other drivers.
Your comments in a minute, please.
Yep, I can. And then secondly, typically we test this in the context of increased competition, which we didn't actually see here. And given that there was changes happening in both the public and private sectors, this is a must opportunity. So what I like about these papers, amazing data, extremely jealous of the type of data that people have when they work on Chinese health reforms. And both papers investigated very interesting, highly policy relevant questions. And to this, I would also add all 4 women presenters, which is really interesting to see. What could be stronger? I do question this idea of US studies being a good starting point for Chinese reforms. And so I wonder if maybe we should be contextualizing this a bit more. How do we account for all of the different things that were happening within the Chinese health reform? These 2 papers are actually quite related, and arguably I could see connections between the identification strategy of one paper and the identification strategy of another. And then finally, I wanted to know more about benchmarking. Are these high or low levels regionally or within China or globally? And that might help explain some of these differences that we might see. So I will stop there.
Thank you, Karen. Those are very penetrating and thoughtful comments, and I'm sure the authors benefit from them. Now, let me turn to Terrence. Terrence?
Can you see my slides?
Yes.
Okay,
now.
good.
Yes.
Yeah. It's a delight to be reading and commenting on reading the 4 papers and 4 presentations and commenting specifically on the last 2. As Karen mentioned, we kind of divide the work. I would respond to the last 2 presentations. So I thought I would like to take each in turn. And first, looking at Chen's work, so I really like the work that's being done here. So the setting or the examination is using a longitudinal panel and also coverage nationally. So this really allows for a nice examination of how the system has evolved over time, as well as potentially being able to link the changes that's being observed to the policy changes that's being applied, and providing a nice companion to also the kind of impact evaluation kind of focus work that's usually applied to study policy changes. So it's quite a nice companion to the kind of contribution as well to the existing evidence. I would kind of go through my comments on this work, and hopefully these comments will be useful to the authors for improving this paper. I wouldn't probably go through every one of them in the interest of time. I think, when I read through the introduction and the contributions, I thought that the paper really wanted to emphasize a lot more on the advantages of the approach, as well as the data that's being used. You have countrywide data, panel data, and what are these advantages that comes with the data, as well as the coverage over impact evaluation studies. For example, for impact evaluation, the often criticism is external validity, especially given the Chinese context where what's implemented across different provinces are quite different. One thing also with the fact that you look at changes over time, it's sometimes a lot. It does take time for policy to filter through changing things on the ground. So being able to kind of look at the time dimension is also quite critical. So the second impression I had in reading the objectives is the introduction and contribution is the extent to which one or the paper can say whether or not the policy objectives are achieved, right? And whether the research methods and the data allows you to say this. So fundamentally, although it's not impact evaluation, we kind of want to link the policy changes to these changes in characteristics, and the changes in characteristics somehow changing choice. In the end, the authors did say this is an association, but I think it would be good to put in a bit more effort in trying to link this 3 dimensions together. So in terms of the discussion of trends is where I think there is an opportunity to make that link, right? The opportunity to provide this narrative of how the policies have affected health systems. So we observe a decrease in the amount of drugs dispensed, a number of doctors decreasing, the doctors' years of experience are increasing. So I guess the fundamental point here is that, when you're discussing the trends, could you also kind of just link this changes that you see to the policies? Are these changes what you expect, given what's been applied in the policy realm? Are there also, possibly evidence on unintended effects? I kind of highlighted this too. There's a decrease in doctors and increase in doctors' experience. Does it kind of point to younger doctors leaving the rural area? That's kind of this, as I suppose, along the spirit of trying to draw out the patterns a bit more. In terms of the results, it's a panel decomposition. So I've not used this before, but the intuition here is that changes in the outcomes are explained by changes in characteristics, as well as changes in returns of those characteristics. So I do feel, at least in just reading through the slides and watching the presentation, I think what could be better done is to discuss what's driving the results a bit more, right? So we see that there's a change in the disease composition that led to a reduction in
can you finish in about a minute?
Okay. In village clinic use, and kind of linking the results a bit more. There's still quite a bit of things that I have noted down, but I'll be happy to share the slides with the authors, so I don't have to go through all of them. Switching to Fan's paper, it's a very interesting read. I'm not sure if Fan has mentioned this paper has been published at the BMC Public Health just this year. Congratulations, that's very important work on equity in healthcare use in China. And because this paper is already published, I thought rather than commenting on the paper, given that it's already kind of polished and published, I want to use these findings to kind of lead into this discussion by drawing in this broader context of what's happening in China's health system. Obviously, one key theme of the paper is inequity. The paper finds poor inequity, which is a very good thing. But does it really mean health hospital care use is appropriate? Does it actually mean that health hospital care use is sufficient? Especially in the context of changing disease burden towards NCDs within a realm of aging population and fiscal challenges. The key question here is the current system fit for use? Do you address the challenges in the future? And I think we kind of know the answer. There are two things I kind of like to bring in terms of emerging themes, right? So we saw in the first paper, as well as a bit on the second paper, the growth in the public sector, and then that has significant implications on equity. Broad questions as to what would that change the role of private sector delivery and financing of hospital care? How does that change the relationship between what's provided under the SHI, what's left to the individual in terms of the out-of-pocket, as well as finance through out-of-pocket as well as through private health insurance, and whether or not that would change the equity landscape as a result of that. The last thing is the equity implications of growth in telehealth market. That obviously allow us to be more efficient in using hospital resources by filtering patients to the outpatient setting. But also you have a private market that runs alongside a public hospital where potentially patients can use telehealth services to kind of secure public hospital equipment. So just two kind of emerging trends for us to be thinking about the challenges within the China system. I think I'll stop here.
Thank you, Terrence. You are offering a lot of fruit for thought for future research, and thank you very much. Because we're already 1 minute from the closing time, I want to thank every one of you. I thought we have 4 very interesting papers evaluating China's health reform, what kind of impact they have on the goals they're trying to achieve. And of course, China, there are many other aspects that have not been touched, as well as both Karen and Terrence point out how these studies can be deepened and made more rigorous, as well as the future studies you can do. And I will encourage everyone to pursue the studies and evaluating China's performance, because China really undertook a major study, a major reform, changed the whole health system. And the system will take decades to change, particularly the delivery system. China was able to implement the insurance coverage in 3 years to cover 96% of the people. But changing the delivery system, the behavior of doctors, behavior of the patients, behavior of the hospital management, that would take decades. And so I will encourage everyone to continue the study. Thank you very much. And I think I'm running to the closing time, and I appreciate everyone's contribution. Goodbye.